I am pretty sure you have witnessed someone falling to the ground, their limbs violently jerking, foam is coming out from their mouth, and you're thinking that maybe this person is possessed by a demon. Perhaps you're thinking this person is being bewitched by one of the village people, probably on the dad's side. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. We're just coming off from the back of looking at Season 3 revamped edition of the Bazooka. If you haven't yet watched those videos, please head over and watch those videos. And we shall now focus a little bit about the lectures on the channel. Then we'll go into the MK's exam secrets, then some more lecture videos. Then we'll also look at the shotgun Q&A. So if you haven't yet subscribed, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend that we are doing lectures on the video, and let's go. Here's a warm-up question, which is from an OSCE station. A wife brings her unconscious husband to the emergency department claiming he has been convulsing. Take a relevant history. So I want you to keep this in mind, and we will use this to actually answer at the end of the lecture. So write down your answer right now. You may pause the video, write down the relevant questions that you think you may ask, and I will give you the answer at the end of the lecture. So when you look at the word seizure, it comes from the Latin word meaning cessare. This means to take possession of. So a seizure is just simply defined as an abnormal paroxysmal firing of the cerebral neurons. Most people actually use the word seizure in convulsions interchangeably, but they do not actually mean the same thing. So a seizure is just pretty much doing with abnormal firing of the cerebral cortical neurons, and then a convulsion is what you see with your eyes, an outward manifestation of a seizure. So it is possible to have a seizure without a convulsion. Not all seizures are going to lead to convulsions. So some seizures may actually be subtle or dramatic, and these are often sudden in onset, and they may or may not occur with an aura. I will explain what an aura is. Then the third term that I want you to be able to define is epilepsy. So when you talk about epilepsy, this is simply a recurrent, that's the key word, recurrent. And what do I mean by recurrent? 2 or more episodes of unprovoked. Take note, unprovoked, because if it's due to a certain cause, if a tumor is causing this person to have seizures, we don't call that epilepsy. If it's an infection causing this person to have seizures, we don't call that as epilepsy. So this should be recurrent, unprovoked seizures due to chronic underlying processes in the brain. Now remember that epilepsy is age dependent, and the highest extremities of life, we see the incidence there. So most of the cases actually are before the age of 20 and after the age of 60. So every person that actually has one seizure that's not recurrent, or a seizure that is recurrent due to a correctable cause, we don't say they have epilepsy. It's just a seizure secondary to something. And I had a lecturer, rather a consultant, that used to say everyone is at least guaranteed one seizure in a lifetime. So if it's the first onset of the seizure, then you can't really just say that this person has epilepsy. So what are the phases of a seizure? You have predominantly 3 types of phases, which may not occur in all types of seizures. We have what is known as an aura, which is a feature of a type of seizure that we call partial seizures. I will explain what this is. Then these are not seen in generalized seizures. I'll explain what generalized seizures are. Then you have an ictal phase and a post-ictal phase. So in the aura, this is just like a premonition. So individuals get alterations in their taste. They may taste things, they may smell things, they may see things. Sometimes there may even be some flashing lights. They may also hear things. They may even have this emotional strange feeling, just a strange gut feeling. Sometimes even a feeling of deja vu, an undue familiarity to a situation that you have never experienced, but you feel like as if you're living the moment again. So this is a common feature with partial seizures, and usually this follows just before the larger event. So this is common, especially in the seizures that start off in the temporal lobe. It's uncommon in the generalized seizures. The only time that you ever get a generalized seizure having an aura is a situation where you have a partial seizure that starts off as a partial seizure and then it goes what is known as a secondary generalization, it becomes a general seizure or generalized seizure. That's the only time when you can have a generalized seizure actually having an aura. Then you have the ictal phase where the seizure actually happens. We'll talk about the different manifestations that we can have. Then the post-ictal phase, these are the events after the seizure. So the person may actually experience some drowsiness, confusion, and of course this is the period where the brain is going to be recovering, because every time someone is seizing, their brain is not receiving oxygen at that particular moment. So it means that the longer that they are seizing, the worse it is for this individual. So what are some of the causes of seizures? I want you to remember the mnemonic vitamins. So V for vascular causes like stroke, hemorrhage, atriovenous malformations. I for infections, it could be a meningitis, but strictly speaking, encephalitis, abscesses, toxoplasmosis, cerebral malaria, neurological cysticercosis. It could be T for trauma, especially penetrating trauma, but it could also be occurring with depressed skull fractures, intracranial hemorrhage, prolonged post-traumatic coma, which is usually associated with having a seizure, risk of a seizure disorder. And the rule of thumb is this: if the seizure is actually occurring within 30 days of the traumatic brain injury, then we don't classify this as epilepsy. It's usually just associated with the injury. And then conversely, if the seizure is actually occurring years after the injury, then it's most likely not even related to the trauma. A is for autoimmune, CNS vasculitis, systemic lupus erythematosus. M is for metabolic causes like hyponatremia, hypocalcemia, hypomagnesemia, hypoglycemia, hypoxia, drug overdose or withdrawal, uremia. I is for idiopathic, meaning that in most of the cases we don't really know what the cause is. N is for neoplasms. These are metastatic or primary brain tumors. And the S is just for psychiatric, to remind you that psychiatric. There are also other factors that have been implicated, genetic factors. Epilepsy has been shown to have a family history. Of course, perinatal causes like perinatal asphyxia, birth trauma, perinatal infections. You may have degenerative diseases like Alzheimer's disease, drugs like theophylline, cocaine, lidocaine or lignocaine, and then developmental conditions like cerebral palsy and Down syndrome may put someone at risk of developing epilepsy later on in life or a seizure disorder. What are some of the triggers that can trigger someone to go into a seizure? You may have decreased in sleep, alcohol, fever, flickering or flashing lights, drug or drug withdrawal. Especially if someone has been taking anti-epileptic drugs, then they abruptly stop them, then they may actually trigger seizures. They may actually trigger a very nasty complication that's known as status epilepticus that we will talk about. Now, how do we classify seizures? So previously, the older classification classified them as partial or focal, generalized seizures, and the unclassified type. The newer classification wants us to classify them based on whether we see certain symptoms or we don't. Whether the symptoms are motor manifestations, it could be automatisms, things like boxing, cycling, lip smirking, chewing movements, or it could be clonic or tonic movements. I will explain what these terms mean. Or it could be a non-motor seizure where there's someone just having sensory sensations, autonomic sensations, psychiatric manifestations. That's the newer classification. It's not really a good thing, or rather a good way to learn seizures if you're starting to learn of seizures. The older classification is a very good one because it is quite logical. How is it logical? We can divide them into partial, generalized, and unclassified. So the partial, it means that only one hemisphere of the brain is affected. Now, these can either be further subclassified into simple partial seizures where the consciousness is not impaired, complex or also referred to as dyscognitive partial seizures where the consciousness is impaired, and partial seizures with secondary generalization. They start off as partial seizures, then they have secondary generalization. Then we may have the generalized seizures, the tonic-clonic or the grand mal seizures, the absent seizures or the petit mal seizures, the tonic seizures, the myoclonic seizures, and the atonic seizures. Then of course you have unclassified manifestations like neonatal seizures, infantile spasms, but I won't go into details of this. Now the big difference is this: partial seizures are affecting one hemisphere of the brain, generalized seizures are affecting both hemispheres of the brain. With the simple partial seizures, they could have motor, sensory, autonomic, or psychic manifestations, and of course these do not have any impairment in level of consciousness. The complex or the dyscognitive seizures will have impairment of consciousness, so will the partial seizures with secondary generalization, so will the generalized seizures. Now we'll start and look at partial seizures. So these are the ones that are going to be limited to a part of one cerebral hemisphere. Now these ones often are going to be suggesting that there's something that is underlying, so there is a structural defect that you should actually look for. we can actually localize them in the brain depending on the lobe and the manifestations that we see. Sometimes there are also some EEG readings that can help us localize where exactly the focus of the seizure is, where it started off. So these can be divided into simple partial, where the consciousness is not impaired. For example, someone has one limb that is jerking, which is known as a Jacksonian seizure. I'll go into detail of that. Or it could be a complex seizure where there is consciousness that is lost. Or this is very, very common in the temporal lobe seizures. Or it could be a partial seizure with secondary generalization. Now, let's look at the simple partial seizures. Remember here, consciousness is not lost. The manifestations may either be motor, sensory, autonomic, or psychiatric. So motor manifestations could be focal, clonic, or tonic movements of the angle of the mouth, the fingers, or even the thumbs. And then, of course, this seizure may actually spread over one side of the body. So we call this as a Jacksonian match. So it can actually spread to larger parts of the body. When the convulsion starts off, for example, with the face, it may move to the ipsilateral arm. It may move then to the leg. And then, of course, the visible spread of the activity of the seizure is what we refer to as the march of a seizure. Then we may also have local paralysis. Temporal paralysis of the limb afterwards. You call this as Todd's paralysis. This is one of the differentials that you should keep in mind when you're dealing with patients that have stroke. Could this be a Todd's paralysis? Then with some frontal seizures, you may get some conjugate gaze deviations away from the epileptic focus. So remember that the gaze is going to be away from the lesion. Then, of course, the rest of the manifestations include things like transient sensory abnormalities, flashing and sweating, pallor, and even just odd feelings. Then with the complex dyscognitive partial seizures, which often 60% of the time arise from the temporal lobe, these are going to be associated with impairment of consciousness. Now here the person is actually going to be unable to respond appropriately to visual or even verbal commands during the seizure, and they will also have an impaired recollection of the events that actually happened during the seizure. And these seizures actually are going to begin with an aura. So a patient may have this rising feeling of the epigastrium, they may have nausea, they may have fear, they may have hallucinations, which could be either olfactory, visual, where they have micropsia, where the images that they see are much smaller than they actually are. And then macropsia, the things that you see are much larger than they actually are in reality. Then you may have auditory and even gustatory hallucinations. Then you may also get some complex illusions. For example, having experienced an event, it could be a deja vu, it could be a jamais vu. Then of course, the ictal phase is going to start off suddenly, where there may be a behavioral arrest, there may be a motionless stare, and this may actually go on and lasting for about 1 to 2 minutes. Now we have another type of seizure that actually looks like this, with an absence seizure, which is very common in children. Now these absence seizures here, the difference between this type and the absence seizures is that the absence seizures usually have a short duration, so they'll last for 10 seconds and you have a lot of them occurring during the day. Then of course these are going to be accompanied, the partial seizures which are complex are going to be accompanied with automatism. There may be some involuntary autonomic behaviors like repetitive complex activities like chewing, lip smirking, picking movements of the hands, even displaying certain emotions. Then in the post-ictal phase they may have confusion, but they usually transition to a full recovery in minutes to hours. Now with the partial seizure with secondary generalization, so this one starts off as a partial seizure, as a focal seizure, then it spreads and affects both hemispheres. So most of them tend to be tonic-clonic types, and it's actually very difficult to differentiate between this type of seizure and a generalized tonic-clonic seizures. And remember, this is the only time where a generalized seizure is going to have an aura. So here are some of the simple seizures and some of the manifestations. Remember that there are different lobes of the brain. You have the frontal lobe, which is obviously going to be responsible for your movements, your decision making, your temporal lobe, which is pretty much where some of these sensations project to. You also have your parietal lobe, where the somatosensory area projects to, and the occipital lobe, where the visual cortex is. So if you have the temporal lobe seizures, which are by far a quite common seizure, you may get autonomic symptoms like a rising sensation or pain in the abdomen, vomiting, flushing, pallor, altered heart rate. Then you may also have altered higher functions like deja vus, jamais vus, amnesias, altered emotions, delusions, hallucinations, which could be olfactory or gustatory. dysphasia, which also happens in the post-ictal phase. You may get some motor manifestations like complex movements like singing, driving, undressing, some automatisms like lip smirking and even fumbling. Then with the occipital lobe, you're going to be having the visual cortex being affected. So they may have visual symptoms where they see shapes, they see flashes, and the shapes are very colorful and they are more circular as compared to what we see in migraines. In the parietal lobe, where you get the somatosensory area, so these are going to have some abnormal sensations like tingling and numbness. Then of course the motor manifestations can happen if it spreads to the precentral gyrus anteriorly. Then with the frontal lobe, you're going to be having the motor complex being affected. So this is going to be causing abnormal movements of the eyes, the head movements, pedaling movements, or even motor arrest. Then of course the onset and the timing is usually quite short. You get this quick onset with a rapid recovery, and it can occur at night, and they come in clusters. You may sometimes have a Jacksonian match, which I told you about. And of course you may have some speech symptoms like vocalizations, dysphagia. You may even have speech arrest. You may have some behavioral changes, and afterwards there is some weakness that the patient may actually have, which is known as a Todd's paralysis. I talked about this. Then with the benign Rolandic fissures, this is actually the most commonest epilepsy syndrome in children, especially aged 5 to 10 years. So it starts roughly around the central sulcus, or what is referred to as a Rolandic fissure. Remember that this is going to be dividing the frontal lobe from the parietal lobe. So nocturnal seizures may actually happen where there's facial twitching, including eye flickering and lip smirking, aphasia, salivation. And here there is no true post-ictal phase, but the patients may actually feel a little bit weak after the seizure, and they may have some outward sensation. Sometimes this can actually progress to a generalized tonic-clonic seizure. So this may be a partial seizure with secondary generalization. So there are some terms, before I actually come to the generalized seizures, there are some terms that I want to actually put out there. So tonic just simply means contraction of the muscle, continuous contraction of the muscle. Clonic means, or it's referring to clonus, where there is spasmodic contraction. So contraction, relaxation, contraction, relaxation. So what about the generalized seizures? So remember that these are going to be occurring where there is abnormal electrical discharge from both cerebral hemispheres simultaneously without any detectable focus of onset. And usually there is going to be associated loss of consciousness or awareness. So you may not be able to even know that you had a seizure. So we'll start with the first type of seizure, which is the generalized tonic-clonic seizure, or the grand mal seizure. So these are motor manifestations. So this is the most common type of seizure, and most likely what you will see in the hospitals when the patient comes in. So it's seen in genetic epilepsy syndromes, and the seizure actually may also arise from metabolic abnormalities like hyponatremia, alcohol withdrawal, certain medications, and even CNS infections. Now this seizure just actually begins without any warning. So there is no aura, there are no focal manifestations. So it just begins boom with the ictal phase. Now in the ictal phase, the patient is actually going to be having two main phases. There's what is known as the tonic phase, and there's what is known as the clonic phase. So in the tonic phase, there's just this sustained contraction, this tonic contraction, stiffening of the muscles throughout the body. So remember when the vocal cords actually stiffen, or the respiratory muscles and the muscles in the larynx stiffen, this is actually going to produce a loud moan or a loud cry before the patient actually has a seizure. Kind of like when someone is being possessed, they have this loud outcry. And then of course there is also a tonic posturing. The respiration is impaired, the patient actually falls to the ground. They may even bite their tongue at this moment because of the contraction of the jaw muscles. Then after about 10 to 20 seconds, you get this now evolving into the clonic phase, where there's going to be this bilateral violent jerking of the whole body, and this usually lasts another minute as they reduce in frequency. Then you have the post-ictal phase, where the patient may become unresponsive. They may have muscle flaccidity, they may have excessive salivation, they may have frothing at the mouth, and this can actually cause obstruction, and it can cause stridorous type of breathing, and sometimes it may cause partial airway obstruction. The bladder and bowel incontinence may occur, and obviously these patients are going to regain consciousness over minutes to hours, and during this transition there's going to be periods of confusion. There may be headaches, muscle aches, and fatigue that can last many hours, so they tend to sleep quite a lot after this seizure. Then you have the absence seizures, or the petit mal seizure. These are non-motor. So these are going to be characterized by this sudden and brief lapses in the consciousness without any postural control. quote unquote zoning out. So the seizure is actually going to be lasting only a few seconds, and consciousness actually returns as sudden as it was lost. Now, you may think that this is not really a big deal, but imagine this. Suppose you have a child that's in class and you have 100 of these in a day and not able to pay attention in class. So this is usually manifested as a drop in the performance in school. So usually there's going to be this blank stare. It's like the staring into nothing, and they have this subtle motor manifestations like blinking of the eyes, chewing movements. Here there is going to be no post-ictal confusion, and the seizure actually can occur as many as 100 in a day. And usually it's going to be detected as unexplained daydreaming and a decline in school performance. Like I said, if your mind keeps zoning out for so long, then it becomes a big problem. So typically the absent seizures are never due to acquired lesions such as tumors. They're usually just a manifestation of primary generalized epilepsy. And they're going to be beginning in children. Most of the children are between 4 to 8 years, but they do have a good prognosis. So 60 to 70% of the cases actually spontaneously remit before or during adolescence. And of course, the children with absent seizures may actually go on to develop a generalized convulsive seizures. And usually when we do our EEG, we're going to be seeing these 3 Hertz spikes with slow wave complexes on the EEG. And of course, the absent seizures are often confused with the complex partial seizures of the temporal lobe epilepsy. Now, what about tonic seizures? Here you just simply have tonic stiffening or contraction of the body without the violent jerking. And then in myoclonic seizures, these are actually characterized by the sudden brief muscle contraction that may involve one part of the body or the entire part of the body. So there is this sudden jerk of the limbs bilaterally, usually the arms, it can be the face or the trunk. It may actually even lead to a patient actually falling. They may actually be single or they may be multiple, and they may even occur on waking up, or actually they're supposed to be walking, not waking up, walking. And there is actually a normal physiological form of a seizure. You know what happens when you're just about to sleep and your body has that sudden jerk? It's known as a hypnic jerk. It's actually a myoclonic seizure. It's a type of a seizure, but it's not pathological. It doesn't mean you have a problem. It's a physiological seizure. Then you may have pathological seizures, which are going to be seen with metabolic disorders like uremia, your degenerative diseases of the CNS, or even anoxic brain injury. Now, these ones are often not epileptic type of seizures. Then we have our atonic or akinetic seizures. So these are going to be characterized by the sudden loss of postural muscle tone lasting 1 to 2 seconds. It's very difficult to distinguish these from syncope, from fainting. Then of course the consciousness is briefly impaired. It's usually manifested by the head dropping and or even a nodding movement. And then the longer the seizure is taking on, then this patient may actually collapse to the ground. And these are primarily seen with inherited forms of childhood epilepsy. Now, what's our diagnostic approach to a patient that has seizures? Because I've explained the different types of seizures that we have. So we have our history, we have our physical examination, and we have investigations. So on our history, we should strike to aim actually what happened before the seizure, what happened during the seizure, what happened after the seizure. So it's very important to have a witness account. So was there any prodromal symptoms? Did they have any aura? Did they have any sudden feelings, seeing certain things? Then what happened during the seizure? This actually needs someone who actually observed this happening. Did they have this violent convulsions, jerking of the limbs? Was there any automatism? Was there any brief syncope or blackout? Was there any pallor that was noticed? Then post-ictal, what happened? Was there any confusion, any headache? Did they recover rapidly? Was there any urinary incontinence, myalgias, tongue biting, oral lacerations? These are all clues to the proper diagnosis. Then of course we should look for causes or risk factors. So ask for any fever. In cases of infections, any CNS infections, current or previous that were treated, head injury or trauma that happened previously, stroke, developmental abnormalities, or even their HIV status, a family history of epilepsy, and a social history of alcohol, recent travel in the case of malaria, not sleeping under the mosquito net in the case of malaria as well, sleep deprivation, which is a triggering factor, prolonged standing. Then of course you may also ask about their diet, especially with pork. So this is with neurological cysticercosis and all those parasites that affect worms, then, or rather pork. Then the general electrolyte intake. Then of course the past medical history of them having previous seizures in the past. This could be an epilepsy, and if they're taking any medication. Then on your physical examination, remember that you should perform a complete neurological examination, perform a complete cardiovascular examination because you want to rule out stroke. Check for any organomegaly, which could point you towards metabolic storage diseases. You can even examine the skin to look for any evidence of neurofibromatosis. What investigations are we going to do? So we may do an electroencephalography, which is not routinely done in all the hospitals in the country. Then this is actually the most useful test in the diagnosis of a seizure. So it should be performed whilst the patient is awake. It should be performed whilst the patient is asleep. So if you get an abnormal EEG, this is going to support the diagnosis of the seizure. It may actually even give you information about the type of the seizure. But remember, an abnormal EEG is not adequate for a diagnosis of seizure, and a normal EEG can actually even be found in patients that have epilepsy. Get some neuroimaging, so pretty much preferably an MRI to check for any space-occupying lesions in the brain. A CT scan of the head can actually also be quite helpful. And remember that the MRIs and the CT scans are going to be indicated because they rule out any structural lesions as the cause of the seizure. Other labs that you can do: a full blood count to rule out any infections, urinalysis, serum glucose estimation to rule out hypoglycemia, liver function tests and liver enzymes to rule out hepatic encephalopathy, renal function tests, serum urea for in the case of uremia, electrolytes and creatinine. Electrolytes that you're interested in: sodium, which may be low, calcium, which may be low, magnesium, which may be low. Do your blood gases to rule out hypoxia as a cause. A lumbar puncture, when you have ruled out any other contraindications for a lumbar puncture, then this is going to be assessing for any infection or inflammatory diseases. You can also do a toxicological screening and even screen for certain antibodies like anti-nucleic acid antibodies, anti-double-stranded antibodies in the case of SLE or systemic lupus erythematosus. What's our differential diagnosis? This could be syncope, it could be a psychogenic seizure, a hysteric conversion. So this is where, for example, someone owes you money, they come and you fake a seizure. That's just a random example, so they're faking it. It could be a transient ischemic attack, which is in the background of, or rather in view of strokes or cerebrovascular accidents. It could be a migraine. What are some of the complications? Early complications include status epilepticus, we'll talk about it, accidents, hypoxic brain damage, you may have sudden death. Then late complications, it may lead to mental retardation, but I don't want you guys to use the term mental retardation. I want you to use the term learning disability, because this is rather a bad term to put on someone. Then of course you may also have impairment of intellectual function. You may have psychosocial complications, the social stigma of people that are living with epilepsy, because they generally think like as if they are possessed with demons or something like that, of course, which is totally ridiculous. Now, what's the management principles? So remember that in someone who has a seizure, you pretty much want to treat the underlying cause. So if there's a metabolic problem, treat that. If it's hypoglycemia, hyponatremia, drug intoxication, treat that, correct that. If it's a structural lesion like a tumor, you should remove those surgically, or you can treat them using radiotherapy or chemotherapy. We avoid the precipitating factors. So maintain normal sleep, avoid taking excess alcohol, reduce stress with physical exercise, meditation, counseling. And of course, if all these things are not working, we can also suppress or control the recurrent seizures with anti-epileptic drugs. I'll give you the common drugs that we use currently. Then of course the goal is to completely control the seizure and to prevent the development of complications and the socioeconomic consequences. Now, what are we going to manage someone who's actively seizing? So remember, this is an emergency. So the first step actually in treatment is making sure that you secure this patient's airway, because there's a high risk of this person actually becoming hypoxic and their brain not receiving oxygen. The longer that they're actually seizing for, the more hypoxic damage you're actually going to be causing. So your ABCs, your A for the airway, ensure that the patient's airway is patent, suction any secretions if there are any, and then when the patient is actually actively seizing, put them on their side to prevent them from biting their tongue and to prevent them from aspirating. So way back we used to use a mouth gag, but this is currently being discouraged from being used, because I even had a patient where we used the mouth gag, and unfortunately when I got there I found that they had already put a spoon in his mouth and he even lost a tooth. So avoid these. Then ensure that you check the patient's breathing, gain venous access. I always say this to my students: any patient that has epilepsy or seizures that is admitted to the ward must always have a cannula, otherwise you will struggle. Then, of course, monitor their vitals. During the ictal phase, you may want to immobilize the main joints, clear away the area to prevent any injury. So most of the seizures are going to be lasting only a few minutes, and they may end spontaneously, but anything that is prolonged, meaning more than 5 minutes, or if it's repetitive, then you want to treat them with rectal diazepam or intravenous lorazepam or bucomidazole, or you can even give them IV diazepam, 5 to 10 milligrams. Then once this has been achieved, then we can actually go to the next step where we evaluate the patient, we treat any underlying cause. Then of course, if the patient continues to seize, we manage them as a status epilepticus, of which I will talk about. So if someone has a seizure for the first time, it's not indicated that we should start them on anticonvulsant therapy unless if this patient has an abnormal neurological exam, or if they're presenting with status epilepticus, or if there's a strong family history of seizures, or they have an abnormal EEG, or this is the first time seizures are not generally well treated with the long-term anticonvulsive therapy. Those are the only scenarios where we actually put a patient on anticonvulsant therapy. Now, what are the indications of you actually putting them on? Let me just emphasize on this. Remember, number one, recurrent seizures of an unknown cause, put them on anti-epileptic drugs. If there's a single seizure due to either an identifiable CNS lesion, a tumor, infection, or trauma, such that you know that this person is going to be having these recurrent seizures, you may put them on anti-epileptic drugs. If there's an abnormal neurological examination, if they present with status epilepticus, if they have post-ictal thoughts paralysis, if there's a strong family history of a seizure disorder, if there's an abnormal EEG exam, put them on anti-epileptic drugs. So the anticonvulsant therapy is not often initiated in a patient with a single unprovoked convulsion, or in patients that have normal neurological examinations, or normal imaging studies, or normal EEG, unless if they have a second seizure or they experience these recurrent seizures. So what are the principles of using these anti-epileptic drugs? So we want to introduce the anti-epileptic drugs usually at a low dose. We slowly titrate them upwards until we reach or we control the seizure and the side effects become acceptable, or rather until the side effects become unacceptable. The aim is to actually control them with monotherapy, with a single drug. 70% of the patients actually will have their seizures controlled with a single drug. If the seizures are not controlled with the first drug, then we can actually gradually introduce the second agent and slowly withdraw the first drug. Remember, we don't stop these drugs abruptly. Then if still they're not seizure free, then we can actually use combination of therapy. Now remember that epilepsy is one of the few disorders where we can actually use brand names, your non-generic names, when we prescribe, to ensure that you have consistent drug levels, because different companies make their drugs in slightly different ways. Then of course we should measure the drug levels in their body, but this may not be needed and is only reserved for assessing things like compliancy and toxicities. But measuring the levels of sodium valproate or valproic acid is rarely useful actually, as the levels do fluctuate quite widely. There are some interactions between anti-epileptic drugs, whether they're given with other medications, for example, even with other anti-epileptic drugs, which is, for example, sodium valproate and lamotrigine, but the newer drugs that are being put on the market have less drug-to-drug interactions. You can always look this up in your BNF, you can always look this up online. And then phenytoin is no longer going to be considered as a first-line anti-epileptic drug. It's only going to be used in the management of the control of status epilepticus, or emergencies associated with seizures. So what are some of these drugs that are used? So I've put a table here that's quite high yield. So partial seizures, which are simple, complex or partial with secondary generalization. Our first line is your carbamazepine. Ignore the phenytoin over there. The alternative could be valproic acid and lamotrigine. So this therapy may be stopped if the patient actually is free from seizures 2 to 3 years. Then with the generalized tonic-clonic seizures, first line is valproic acid, lamotrigine. Alternatives are carbamazepine, phenobarbital, phenytoin. Absent seizures, valproic acid, ethoxusamide. Secondary seizures, second line rather, is lamotrigine, clonazepam. Absent seizures and atypical absent seizures, myoclonic and atonic seizures, the first line is valproic acid, lamotrigine, clonazepine, and topiramate as second line. So notice how valproic acid actually shows up on one of these. So this is one of the drugs that I want you to actually remember in the cases of epilepsy and seizures. So here are the details of the drug. So with carbamazepine, we usually start off with 100 to 200 milligrams orally, twice a day. Then we gradually increase the dose by 200 milligrams every week until the best response is achieved, or the maximum dose of 1,600 milligrams in total per day is achieved. Some side effects include aplastic anemia, dizziness, drowsiness, skin rash, and even transient diplopia, which is a double vision. With valproic acid, this can be used for all the types of seizures. So we start off at 600 milligrams orally once or twice a day. Then we can increase by steps of 150 to 300 milligrams every 3 days. Our maintenance dose is about 1 to 2 grams per day. Here, side effects include menstrual disturbances, extrapyramidal side effects, aggression, anemia, confusions, nystagmus. You may have transient hair loss. Regrowth actually may cause this hair to be curly. Then you may also have weight gain. With lamotrigin, the dose is actually about 25 milligrams orally once a day for 14 days. Then we increase to 50 milligrams once a day for another 14 days. Then we increase in steps up to 100 milligrams every 7 to 14 days, so every 2 weeks. Then the maintenance is about 100 to 200 milligrams daily in 1 to 2 divided doses. Then we increase necessary up to 500 milligrams daily, and we titrate, and this actually should be repeated if restarting after internal or after you have more than 5 days. Then the side effects include blurred vision, nystagmus, diplopia, anemia, exacerbation of Parkinson's disease, rash, and even tremors. Then with phenytoin, you start off at 100 milligrams twice a day or 3 times a day, which may be gradually increased to a maximum of 200 milligrams orally 3 times a day. So that's 600 milligrams daily. Then the side effects are going to include nystagmus, gingival hyperplasia, remember this, coarsening of the facial features, toxic hepatitis, and even liver damage. Then what about status epilepticus? Because this is one of the very, very feared complications of seizures rather. So this is actually a seizure that is lasting more than 5 minutes. So we used to use a threshold of about 30 to 35 minutes. But of course, you're not going to wait until someone is seizing for continuously 30 minutes, because that's a very, very long time. So our threshold is now at 5 minutes. Or if someone has 2 or more seizures without any recovery in between, then we consider them as having status epilepticus. Remember that this is a medical emergency, and any seizure that is actually lasting more than 5 minutes is going to be unlikely for it to stop spontaneously, and it carries a permanent risk of neuronal damage. Then these usually occur in non-epileptic patients, and this may actually even be the presenting complaint for some patients. So the longer the duration of the status, the greater the risk of permanent cerebral damage. So you may also have muscles being torn apart, myoglobin being released, so there is also a risk of having acute kidney injury, especially in convulsive states of epilepsy. Then not all status epilepticus is actually convulsive. You may sometimes have this in the absent seizures. For example, you have status which is non-convulsive, where the patient is just having this continuous, distant, stuporous state, and of course, focal status also occurs. We may have a condition that's known as epilepsia partialis continua, which is pretty much a continuous seizure, or continuous activity of a seizure in one part of the body, such as the finger or the limb, without loss of consciousness. So this is often due to a cortical neoplasm, or even in the elderly, it may be due to a cortical infarct. What are some of the triggers of status epilepticus? Non-compliance with the anti-epileptic drugs, CNS infections like encephalitis, metabolic derangements like electrolyte imbalances, altered glucose. You may have alcohol withdrawal of certain drugs, tumors, trauma, stroke, and even refractory epilepsy. What are some of the clinical features? So generalized status epilepticus is obvious because the patient is going to be having convulsions, but after 30 to 35 minutes of uninterrupted seizures, then the signs actually become very, very subtle for you to pick up. So the seizures are going to be tonic-clonic. They may have fever. They may have sweats. Then, of course, the patients may have mild clonic movements of only the fingers or fine rapid movements of the eyes. It can also be non-convulsive, and it's going to be characterized by confusion, altered mental state, odd behavior, and even sometimes derealization. What are some of the complications of status epilepticus? Aspiration is a very big thing. Hypoxia, so death of the neurons due to cerebral hypoxia. Metabolic acidosis, hypotension, hyperthermia with rhabdomyolysis and myoglobinuria, that's the myoglobin damage in the kidney leading to acute kidney injury. Multiple physical injuries like vertebral bone fractures and even irreversible neurological injury. How do we manage? ABCs also. Keep the airway patent, maintain their breathing, put them to the left lateral side. administer oxygen, monitor their ECG and their vitals, secure an IV line, and draw bloods for investigations, your metabolic abnormalities, so check your glucose, your electrolytes like sodium, potassium, chloride, bicarbonate, calcium, and magnesium, your drug screens, even your alcohol blood levels, your anticonvulsants levels. Then the pharmacological management, we administer thiamine and glucose. So ideally, we should assume that they are hypoglycemic, because hypoglycemia is one of the causes of seizures. So thiamine 25 to 100 milligrams orally once a day if they have a mild deficiency, 200 to 300 milligrams orally in divided doses daily, and intravenous infusion actually should be given over 30 minutes. Then glucose is also given 20 to 50 mils of 50% solution, or 40 to 100 mils of 25% IV solution. That's generally about 10 to 25 grams of glucose. Our first line is your benzodiazepines. Of course, this is different in neonates. This is in adults. So this is your first line. So we're going to start off by giving either your diazepam or lorazepam. If you're given lorazepam, is 4 milligrams as a slow bolus. You give it over 3 seconds. We can repeat this after 10 minutes if necessary, but you should be very, very vigilant of the respiratory rate so that you don't stop this person's respirations. You can give diazepam 5 to 10 milligrams once, then you repeat after 10 minutes. If they still continue seizing, then this is known as established status. This was early status up to 30 minutes. If after 30 to 90 minutes, this is known as established status. So we give them phenytoin, 15 to 20 milligrams per kg, IV diluted in 10 milligrams per mil in normal saline into a large vein at 50 milligrams per minute. You should monitor the ECG. You may sometimes use phosphenytoin, which is a prodrug of phenytoin, and it can be given faster than phenytoin, so the dose is actually expressed in phenytoin equivalents. So 1.5 milligrams of phosphenytoin gives you 1 milligram of phenytoin. So you give 15 milligrams per kg of phosphenytoin, so that's 15 milligrams multiplied by 1.5, so that's 21.5 milligrams. And of course, we dilute it in 10 milligrams per mil in saline, and we can give it at a rate of 50 to 100 milligrams of phosphenytoin per minute. Then if they still continue seizing despite you giving your phenytoin, you can actually give a second loading dose of phenytoin or phosphenytoin with an additional 5 to 10 milligrams IV loading dose, or moving directly to the next step. So if the seizure continues, then the next step is for you to administer your phenobarbital or your valproic acid. So your phenobarbital is given at 10 milligrams per kg IV diluted 1 in 10 parts of water for injection, and you give it at a rate less than 100 milligrams per mil. Or you can give valproic acid IV 25 milligrams per kg. By this time, you should have even involved your consultant or asked the senior for help. And if the patient is still seizing, then we have to actually inform general anesthesia, because this is a refractory status over 90 minutes. So you should inform anesthesia, intensive care, intubation, ventilation may be required. Propofol can be given as a bolus, 2 milligrams per kg. Then we repeat this with a constant infusion of 5 to 10 milligrams per kg per hour. Thiopental sodium, even your midazolam can actually be used in infusions. You should also monitor the ECG and the EEG continuously. Then of course reinstate the previous anti-epileptic medication via the NG tube, establish a diagnosis, so get a CT scan, get an MRI to find the underlying cause. And remember that 25% of the patients that have apparent status actually turn out to be pseudo status. Here's a warm-up question. A wife brings her unconscious husband to the emergency department claiming he has been convulsing. Take a relevant history. So you want to first greet the patient. If it's a physical OSCE station, introduce yourself, gain consent. Demographics are very important. So the name of the patient, the age of the patient, the occupation, the residence. Then ask the wife how she describes the convulsion. What happened before? What happened after? What happened during? What happened after? So what was the man doing before the convulsion? Did the man mention having experienced any odd visions, taste, or smell before the convulsive episode? What happened during the convulsion? How does the wife describe the convulsion? Was it part of the body? Was it the whole body? And did the man fall during the convulsion? Then did he lose consciousness after the convulsion or during the convulsion? Did he experience any fecal or urinary incontinence? Did he bite his tongue? Did he experience any memory lapses afterwards? Was there any recent trauma or injury? Does he eat any pork or poorly cooked meat? Is there any history of fainting, blackouts, or seizures? Ask them if there's a personal history or family history of diabetes, hypertension, epilepsy, TB, and HIV. Ask if the patient had a similar presentation before. Is the patient on any medication? If they are, what kind of medication? Does the patient drink? If they do, what kind of alcohol do they drink and how much? Does the patient smoke? If they do smoke, what kind of things do they smoke and for how long have they been smoking? And then ask the wife if she has anything else to tell you. Then of course, if there's nothing else to tell you, then thank the patient and you're done with your OSCE station. I really hope that you enjoyed everything that I taught you on seizures, epilepsy, and status epilepticus as well as epilepsy. If you did, consider subscribing to Zambia and Beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.